All right, settling back in. Let's do tachycardias. So this is my favorite. Here's the other weird thing about me. When I go into work, I'm highly germophobic. I think that's partly why I picked emergency medicine, because it's the one specialty where you can shake someone's hand with gloves on. It doesn't seem weird, you know? But I'm highly germophobic, and so I go to work, and they're always like, oh yes, cleaning crew has arrived, which for the longest time I took personally, because I was like, is that because I'm Indian? I mean, really? Okay. But so, I come in, I disinfect like the whole area and the seat, and usually what happens, this is like, a couple minutes before shift change, and as you're doing this, you're trying to get yourself cleaned up, the nurse comes in, can you come see this patient? He looks sick. And so you're like, well, is he really sick? Because I'm not done disinfecting the phone yet. Then it's going to throw like my whole OCD off completely. I have to do the whole thing from scratch, right? So here you are, can you come see this patient? Okay. So you walk in the room. You have this nice young gentleman who looks a little clammy, diaphoretic. Sure enough, on the monitor, they've put him on the 5-lead because he was 32 and he had all these complaints and has a history of fibromyalgia and some other things going on. So they humor him and put him on the 5-lead, and sure enough, his heart rate's going pretty fast. And you walk up, introduce yourself, and this is my favorite one, is when the patient looks at you and says, please don't let me die. Because most patients don't say that unless they impendingly feel like something bad is going to happen. I've had a patient say that to me one time right before he coded and had a traumatic arrest after a motor vehicle crash. And so that has stuck with me, so I make a joke out of it in the slide, but when a patient says to you, don't let me die, they probably know something that you don't know. But don't panic, here's the EKG. And so you say, well, I have to take shift change. I'll be right back, right? All right, stay calm. It's okay, it's good, because last night, lucky you Netflixed Grey's Anatomy. This is the cool thing about also emergency medicine, right? Your patient comes in, they give you this whole slew, this litany of whatever they're telling you, and you sit there and you kind of, yeah, You put on like your really best interested face, and then you say, I'll be just right back, okay? And you go to your computer, you sit down and you Google it. And then you come back in and you're like, oh yes, so I was just looking through your chart, you say. The chart, right? Which is on the same tab, just on different parts of the computer. All right, conduction, same thing, right? So you have a sinoatrial node, it fires, gets to your AV node, then you have some Purkinje fibers and some bundles and some branches, and then the whole thing, if it's working correctly, works correctly, and you have a nice squeeze and out comes some blood. Now, what causes fast heart rate? Simple, 2 things. Either there's too much of it happening, so altered impulse formation, or it's being conducted in a way that we didn't intend for it to be conducted, right? So either altered impulse formation or altered impulse conduction, just 2 major categories of what makes things go fast in the heart. In terms of altered impulse formation, either you have enhanced automaticity. So some little node, some little pacemaker got very excited this morning and is just kind of beating its own little drum just way too fast, okay? Or there's some kind of an imbalance, right? There's a triggering because of your gated potentials. Remember those? Ugh, ew, right? Those 0-1 action potential things. So there's too much or too little mag. There's too much or too little calcium, too much or too little potassium. Or your patient has ventured out to the local e-cigarette shop and bought some tea and has had some tea to drink, and now there's been too much of some toxic effect from some tea that the patient drank, right? So either intrinsically there's too fast of a rate, or something has triggered this rate to be too fast. In terms of impulse conduction being erratic, there's an accessory pathway, right? So we as humans are path of least resistance. If you are walking down the strip and there's a big group of, I love the 5 wide walkers. So I'm a runner, and nothing makes me angrier than when people walk 5 wide. And you're like, why are you walking 5 wide? Excuse me, on your left, hello. And then finally I just go, get out of the way, right? You run fast. But so if you're on the strip and there's an option to go faster, you're going to pick the faster option, right? So electricity is no different. It's a very simple concept. Oh, this route looks faster, I'll take this route. So now you have a pathway that's easier to access, and you're going to conduct down that route. But that pathway does not have that built-in stop block, so now it's conducting way too fast to the ventricle. Or you have a pathway that's like a little circus. So the node fires, gets to the ventricle, and then it's like, wee, right? Going around and around like a little circus. And that's what causes impulse conduction to be tachycardic. So what do you do with a tachycardic patient? What do you do with any patient? This patient potentially could go into something a lot worse than what you're seeing on the EKG. Now, I know some of you are looking at that and thinking, oh yeah, critical care time. You can bill for that, right? Good thought, not so good for the patient, right? Is your patient stable or unstable? Okay, so if you're out here running on the strip and you're a fairly healthy person and you're tachycardic, you're likely to be stable and you can stop and have a conversation, tie your shoe. If you're not, and that compensatory mechanism is not firing, now maybe you're hypotensive, dyspneic, right? Looking a little diaphragmatic like you're about to go south. So that is an uncompensated patient. How fast is the rate? This is important because here again, a number will help you sometimes determine one rhythm from another rhythm simply because of its rate parameters. We'll talk about that. Narrow or wide, right? Is this a wide tachycardia or a narrow tachycardia? Is it regular or irregular? So very similar themes, right, that we talked about from before. But again, we're keeping this very consistent so we never miss important factors on the EKG or on the rhythm strip for the patient. And what's causing the tachycardia, right? Is this coming from the sinus cavity or is it coming from somewhere else within the heart? So your EKG, never be afraid to turn to the person that handed you the EKG if you don't like the way it looks and say, could you please get me another EKG? Now, sometimes you'll get a look like many of you are giving me right now, which is this kind of like, ugh, really? Okay? But why would you use a modality that you can't really read to make a diagnosis about a person? You wouldn't, right? So ask for another EKG. If you still can't tell because the rate is going so fast, you can actually double the EKG paper speed, which in terms cuts your rate in half. So it takes whatever that tachycardia is and strings it out so you can go, aha, there's a flutter wave in there. Okay, so that just helped you out a little bit. Again, two types of tachycardias, narrow or wide. Right, we're keeping this very simple. And within the narrows, there's regular and irregular. And in the wides, there is regular and irregular. Okay, so the patient that you have, the tachycardia that they have is going to fall into one of these four categories. Simple. For narrow complex tachycardias, in the regular category, sinus tach, SVT, flutter. Okay, because those are all regular fast tachycardias. In the irregular category, we have multifocal atrial tach and atrial fib, right? So far, so good. So here's a true story. I'm working a shift one morning. It's a very busy day. It's the day that the residents have lecture, so they don't come until about 2 in the afternoon. And it's a particularly busy Wednesday. And the PI I'm working with, he turns to me and he says, I don't feel good. And being the empathic soul that I am, not. I'm in the Air Force, come on now. So I'm like, okay, we'll drink something, you'll feel better. And he's like, no, I mean, like, I really don't feel good. And I'm like you're gonna throw up, you don't feel good, you have to blow your nose, you don't feel good. Like, what is, I don't feel good? I'm like, we're really busy this morning. Right, like, take a number, get in line. And he's like, no, I mean, like my heart, like, it's racing. So I reach over and I'm like, oh yeah, it is. Should have been nicer. Okay, so I said, well, let's slap a quick EKG, see what's going on. So we get an EKG, here's his EKG. Exciting? No, not really, right? What's the rate? Yeah, 120-ish. What's the rhythm? Is there a P before QRSs? Yeah, so it's sinus, tach. Axis, you're up in 1, you're up in F, normal, right? No cousins are kissing, no LVH. The T waves don't look terrible based on what Fred just talked about. There's no ST flattening per se, no ST elevations more than 5. There's a number 5 again, millimeters, right? So this is actually just sinus tach. And so I'm like, okay, seriously, like, get back to work, right? Drink some fluids, get back to work. Okay. But there are some bad things that do cause sinus tach. So of course I was like, you don't think you have a PE or anything, right? Like, if you're breathing okay, you haven't been on a trip, you're fine, there's no like factor 5 Leiden in your family, let's go back to work. Okay. So sure enough, Same person, like an hour later goes, okay, it's back. I'm not feeling good again. And I'm like, oh, you've got to be kidding me. Okay, so we go back to the room. Now we get this EKG. Okay, so now he stopped faking it. And no, you still cannot have dilaudid for this. Okay, so what does he have going on? What's our rate? Oh, you guys are going to have to help me because I can barely see, my age is showing, I can barely see the boxes from up here. 300, 150-ish, right? Okay, like your two dark lines, I say 150. Is there a P wave that's discernible before the QRS? Oh, weird. Okay. The QRS is narrow, right? So this is a narrow tachycardia, right? So we're not calling this a sinus tach, but it's definitely a tach. The QRS is still normal. Regular or irregular? Regular. So if you flip back to your little box of regular, narrow, complex tachycardias, it's not sinus tach, because we know that. There's no P waves. What was left in that box? SVT and a flutter. So this is SVT, okay? So my poor physician assistant is now in fulminant SVT this morning, okay? And he's got me very empathic working with him. All right, so once again, the box that I put on the sheet for you is a simplified version of this very complicated box, but essentially tachycardias are narrow or they're wide. If they're narrow, they're regular or irregular. If they're regular, they're one of these guys. If they're irregular, again, here's AFib, MAT, and then we'll talk about the wides in just a few moments. But again, if you're wide, you're regular or irregular. If it's regular and wide, it's VTAC, right, or AVRT, etc. If it's irregular and wide, it tends to be a polymorphic VTAC or a VFib. Okay, so SVT, again, not the sinus node, but something above the ventricle, above the junction, has taken over. Some little pacemaker has taken over in this Game of Thrones, so to speak, and is now pacing very rapidly the ventricle below it. These are other types of SVT, right? So atrial tach is a type of supraventricular tachycardia. Then there's AV nodal reentry tach. Now, are you an electrophysiologist? No. Are we going to sit there and try to decipher whether this came from an AV nodal reentry or an AV reentry? No. Supraventricular tachycardia until somebody wants to delineate further for you. Okay. So in our little case, here's our physician assistant. Now, what would you do, right? There's a show on TV that's called that, isn't there? What would you do, right? Because it's you and the physician assistant, and big department to run, man, and the residents are not coming back for a few hours. No help is coming. You have patients to see. Plus, I have to take a coffee break soon. I can't just be seeing all the patients by myself. So here he is in SVT, doesn't feel good. His blood pressure, his systolic is about 90-ish, and he's a sizable 6'2" guy, okay? So we could, if we didn't like him, we could find a nice ice bucket and just, right, dive him into it. Have him bear down, although we're not really sure what might happen in the bearing down stage. Code brown. Right? And that would be a whole different code to deal with. Carotid massage. So here's a caveat on carotid massage. If you're going to massage, you pick one side, then the other. Don't do both, please. Right? Okay? Again, unless you really don't like the PA that you're working with, but nice guy. Nice enough, right? Adenosine. Okay? So when I give a patient adenosine, this is absolutely true. You can ask any patient I've ever administered adenosine to, and the nurses are always like, what are you doing? I sit right next to them, I tell them what's going to happen, and I say, you're going to squeeze my hand when you start to feel the pressure. So that way I know that you're having pressure, and you know someone's sitting right here. Now, sometimes they squeeze, and it's really hard, so I usually just make a fist, right, so that way you can't crush your fingers. But that way it gives you a moment, too, because how fast does adenosine work? Fast. How fast is its half-life? How short is the half-life? Seconds, right? Like 6 seconds. So this squeezing should not go on for more than 10 seconds. If you do, there's a problem, right? You're about to start billing for some critical care time. All right, so here's my PA. This was the EKG. Adenosine. Breaks out. Perfect. Fluids, unhook him. Let's get back to work. Let's go. No. I gave him like an hour. All right. I've tried the diving ice bucket situation once in Cleveland with an 8-year-old. It worked really well. It took her a while because she was like, no, I'm not putting my face in an ice bucket. But then her mom was like, pretend like you're bobbing for apples. And it was all very cute, it worked. Okay, next case. You have a 54-year-old female sitting in her gurney, and she says, feels like I am running around this ER and having some pressure in my left chest. So here's her EKG. So this down here, right? These nice, pretty little sawtooth flutter waves. This is atrial flutter. Atrial flutter is not lead specific. So I'm going to say that again. Atrial flutter is not lead specific. What I mean by that is sometimes you'll get the EKG where you have this lead right here that looks flutter, but you don't see that anywhere else. That, my friends, is artifact, right? The patient is shivering or jerked or like the right arm jerked momentarily. Something happened. You won't see atrial flutter in one lead. It's everywhere. Kind of like a STEMI has a pattern, a flutter has a pattern, right? It's in every single lead with this cute little sawtooth flutter pattern that's going on. Right, so this is narrow, QRS complex, regular, very sawtoothy, as you can see there. Very pathognomonic. Again, if you have a rate that's going fast and you are in between, is this a fib or a flutter, have them do a double speed EKG tracing, slow it down, and pull out those sawtooth waves for you. Okay. If you give them adenosine, it would slow them down enough so you could actually see the sawtooth waves. Okay, but the patient will feel terrible. All right. Now you have an 86-year-old male. He's here, he's short of breath, and he's palpitating. He does have a history of COPD. And by the way, his physician that treats him for COPD is about as old as the patient is. Meaning that he might be receiving theophylline. Okay? All right, so this is his EKG. Conveniently, don't you love like when the radiology or the EKG has the arrows already thrown in for you, right? Or the circle? Finding is here. So conveniently, this EKG came off this fancy machine with the arrows already on it to clue you into the fact that some of these P waves don't look like their other friends, okay? So we have a very nice diversity party of P waves going on. So this P wave, if you notice, I like to, by the way, come down to the rhythm strip on the EKG because that gives you a strip of time, right? It's not just a snapshot of like 5 little beats and then it moved into the next lead. So here you pick this nice lead too where you can see nice P waves where they should be nice upright P waves, and then you can kind of follow them out and trace them out, right? So here we have this little P wave which looks very different from that P wave, who kind of looks like this one but still different from the first one. This one is inverted. This little guy is inverted and bifid, right? So all very different P waves, and on top of that the rate is tachycardic. Okay, so this is multifocal atrial tach, and outside of thinking he might have theophylline toxicity, which he might, the big thing from MAT in this day and age to think about when you have it on an EKG, especially in a younger patient, or maybe even an elderly patient, is a PE. Because all of a sudden you have this big strain in the pulmonary arterial trunk, and that right heart has just been pumping along, doing its little thing, and now it would be like me pushing into an offensive lineman, right, on Sunday. So, like a lot of strain, a lot of force, and now it just becomes very erratic and upset and begins to reflux into the right atrium because the blood can't go out because there's too much force. So it begins refluxing back up, and now your atrium becomes very irritable, and this is when you have this kind of chaotic atrial pacing going on, okay? So this would be the one case where you would maybe stop to think, why would this 26-year-old have multifocal atrial tach? And she's short of breath and a little hypotensive today. Okay, maybe it's her PE. So this patient has gone to their clinic visit, and as it turns out on the vitals at clinic, things are not so good for the patient. Imagine they actually had an X-ray in clinic, diagnose a patient with a pneumonia, and they directly admit the patient to the hospital. Like cha-ching, lucky day in Vegas, right? Bypassing the ER. However, in true fashion, the patient becomes unstable, right? Here comes the EMS to take her from clinic to the hospital. EMS loads her up, they get her hooked up to vitals, and next thing you know, they're like, oh, no, she's looking clammy, diaphoretic, her heart rate's all over the map. Oh, we can't take her, they're not gonna take her straight to the floor like this. Job security for us. So she comes to the ER, okay? So this is the EKG that's faxed over to you from the clinic. So if we go through our little system again, what is our rate, give or take? 300, 150, 100-ish? Yeah, okay. Regular or irregular? Irregular, right? Like if you took out your poor man's calipers, everybody knows what those are? So I have calipers, and I made the mistake of actually packing them one time in my overnight bag. I did not know they were in there. I had taken some things out of my work bag in a little pouch and stuck them in an overnight bag and got on a flight. That was fun. Whose bag is this? Right? And it's like where you're like, huh? What is the question? Who's asking? It's my bag. Ma'am, could you step over here, please? And you're like, oh, come on. Like, I'm naturalized. I'm an immigrant. I serve in the military. Like, seriously, man? Again? Right? No fly list. Me. Okay, it's me. Come over. What are these? Oh, they're calipers. What are they used for? And this is when, like, your sarcastic side wants to say, to eat those little miniature hot dogs with. But already, like, you're in trouble with TSA, so you're like, I'm a doctor. And they're like, okay, and what are these used for? Yeah, so that was fun. So we had a little discussion. He was actually very nice, and he was like, well, we'll just duct tape them. You don't have to, whatever. So he was nice and let me get on the plane with them. And luckily, I didn't do anything untoward on that flight. It was good. Don't worry, I'm leaving Vegas today. Nobody panic. I'm out this afternoon. All right, so this is your EKG, right? It's irregular. If you don't have those pointy calipers, you can make poor man's calipers. You take a white piece of paper, right, from your your printer drawer. You take your EKG. You lay the white paper on top of the EKG. You take your pen, for those of us who still have writing instruments outside of computers at work, and you trace the big solid grids onto your white paper. This has now become your ruler. Then you take your ruler and you march out the QRS complexes with your new caliper you made on paper. And if it's regular, right, then your QRSs will fall within your ruler dark marks. If it's not regular, then clearly those QRSs will not fall there, and lo and behold, now you have calipers for free, which are also TSA fly friendly. Okay? So this lady now is in the department. Okay, that was her clinic EKG before she destabilized. Now she's in the department. And this ties in well, actually, with Fred's talk, because what's going on here with her ST segments? Yeah, these don't look so healthy anymore, do they? Before, when her rate was like 100-ish, it's fine. But now her rate has definitely gone up, right? Like 300-ish here intermittently, and then it drops back down, and then it picks back up again. So she's having a little demand ischemia because of this, right? So now she's definitely become an unstable AFib patient. That heart cannot support this kind of rate for much longer. So AFib, your rate can be as slow as 60 if they're nicely controlled on their outpatient diltiazem, and they come in and you get a routine EKG. They can have AFib as an underlying irregularity that you see, but it'll be rate controlled, so 60, 70, 80, whatever. Or it can be as fast as this patient that we're looking at here, 220, okay? So a very fast rate. Stability depends on if they are mentating, they're not hypotensive, they're not about to go south on you, or they have AFib and they're just sitting there talking to you and they're perfectly fine, okay? All right, so that concludes narrow complex tachycardias, right? We had regular and we had our irregulars. I have an Air Force colleague who every time we have our yearly fitness test goes, I think I might have asthma. He's a physician. I think I might have asthma. And I said, why do you think that? Well, I get really short of breath when we go out to run the 1.5 miles. And I said, well, do you always get short of breath when you run? Oh, I only run when we have to run the 1.5 miles. Huh, okay, good. I love it. Kind of like I have self-diagnosed Raynaud's. All right, so we've done the narrows. Let's do the wides. Monomorphic VTAC, right? Regular, very wide complex, okay? Your heart can be normal. You can tend to see a lot of this in kind of like reperfusion arrhythmias, like you've had a STEMI patient who has been given lytics, or perhaps they've gone to cath lab, they're on the floor, etc. You can have some reperfusion instability, and you can have something that looks like monomorphic VTach. Okay. What do you do if a patient's unstable with monomorphic VTach? You shock them, right? It's nice to give them a little something if they're stable before you shock them. If they're unstable, then you're just going to shock them to get them back. Start at 100 joules. And then they can have dilaudid, yeah. All right, VTach, wide QRS, okay? A lot of AV dissociation, right? As you can see here, the ventricle's kind of going, the P wave is just kind of sporadically like trying to fire, but not quite capturing anything to regain control over the pacemaking system of the heart. The rate is usually greater than 120, and it's a nice fast, and you can obviously have sustained versus non-sustained, right? Non-sustained VTach versus sustained VTach. So once again, every so often, the sinus node is actually able to overtake that little ventricle, and you make a normal looking beat. It's called a capture beat. Sometimes you have what's called a fusion beat, so the QRS gets a little bit narrower as the sinus node was able to fire at the right time, but didn't quite get there while the ventricle was also firing itself. But the two coming together made that more narrow looking QRS. Then you go back to this wide QRS complex. So this is very pathognomonic. If you see this on a long rhythm strip for VTach, you'll have these capture beats where they look more like normal sinus beats, and then you'll also have fusion beats with narrower QRS complexes buried within all of your very disorganized looking wide complex VTach. Here's VTach again, right? Big, wide, ugly. Not pretty at all. Polymorphic VTach tends to be irregular, right? So we have these VTachs here, and then the patient's trying to capture, then we kind of disintegrate again, but very wide looking, very chaotic, very irregular rhythm. This is not at all, if you notice, regular like this wide complex VTach was, right? So this is polymorphic VTach, whereas the last one was monomorphic VTach. Non-sustained VTach, right? So you have these nice cute little runs, and then we recapture, okay? This is not a discharge home for sure. Definitely admit this one. Okay. This is the kind of patient too I would, try stabilizing modalities, amio, lido, whatever you like to use, or whatever the pro-AMI study just said about procainamide versus amiodarone. So I just like amio. Again, I'm a simple person. I'm also an Air Force doctor. We have very limited things on planes. So those are things I just tend to know and use a lot and know very well about, even on the ground when I have lots of options. Okay. So here we have this nice monomorphic that kind of just destabilized. Okay. And this is VFib. Okay. It was tacking away until he went into VFib. So now you can bill for critical care time. All right, this rhythm here. If you took out your little cheat sheet of paper and drew your calipers, so those intervals are clearly different from this interval, which is different from that, way different from this one. So it's not regular. Right? Irregularly irregular. And this is what I'm talking about. See up here? See how there's this little fluttery looking thing? But it's really only in V1. This is not likely to be A flutter. It's probably a fib. It's just that this particular lead looks like it's A flutter, but you don't really see it carrying out in these other leads. And we don't have the full 12 either, but that's what I mean by lead specificity for A flutter. What makes the heart go fast? I should throw in here, sleeping in Las Vegas by a nightclub that doesn't stop until 4 a.m. No. Right? So A and B, both altered impulse formation, too much is forming, or it's conducting really abnormally. And last question, I think, of this set. All right, so this EKG, what do we have here? So this rate looks fast to me from up here, like 150-ish, I think I'd call it. Yeah. Narrow is narrow or wide QRS? Narrow. Regular or irregular narrow QRS? Regular. So you have a regular narrow QRS tachycardia. Is it sinus tach? No. Is it SVT? Yes, good. See how simple we made that? We narrowed away what narrow complex could look like.